This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the ARC. This is copywritten 2021. Hi, my name is Brad Kuch. I'm the Director of Respiratory Care and Transport Services at UPMC Children's Hospital of Pittsburgh. I'll be moderating this topic today, which is entitled Respiratory Therapist as a Partner in Prevention and Management of Pediatric ICU Delirium. The objectives of this presentation is to define characteristics of delirium in children, discuss how delirium differs between children and adults, examine how respiratory therapists can help prevent or minimize the effects of delirium. Today, I am pleased to welcome Dr. Sean Barnes. Dr. Barnes is an assistant professor of anesthesia and critical care medicine at Johns Hopkins University School of Medicine, Charlotte Blumenberg Children's Center in Baltimore, Maryland. Neither Dr. Barnes nor I have any relationships to discuss, or disclose rather. Brand names of products and/or medications may be mentioned only as examples of technology. Any use of brand names is not in any way meant to be an endorsement of the specific product, but to merely illustrate a point of emphasis and to provide information and education regarding the availability. Dr. Barnes, welcome to the program.
Thanks, Brad, and thank you for that kind introduction. I was really excited to when I was asked to present today on this topic because I thought it was a rather unique one, and it's not necessarily intuitive to many individuals unless you're living in the ICU like many of us probably are, or at least rotating through. But we will dive in today and sort of jump in. As a brief overview, as Brad mentioned, the objectives will really, I just want to make sure we all are on the same page when we talk about delirium. It can be really confusing for some individuals because they've experienced it, maybe in a snapshot, maybe it was in a personal situation, not in a clinical one. And so I think it's really important to sort of boil delirium down into its core features. Because many of us take care of children and adults, we'll sort of bounce off that and talk about the differences. And then really sort of along the way, I'm going to highlight where in my own practice, I've noticed that respiratory therapists have been valuable team members in the care of children who are in the ICU and experiencing delirium. But it's not limited to just children. These principles would be applicable to adults as well. I'm really big on advocate of professional social media use. I just want to give a quick plug. I usually do it at the beginning of most of my talks. My username on Twitter is at Dr. Sean Barnes. Pretty easy to find me. I've included the handle, my Twitter handle, in the corner of all of my slides. Feel free to take screenshots or pictures and share. None of the information in the talk today is embargoed, and it's a great place to communicate and engage with people. I didn't include hashtag respiratory therapist. I know that's actually a pretty big one on social media, and the one I included in a tweet when I was talking about how excited I was to give this talk today. Some of the other relevant hashtags for the topics being discussed are delirium, PEDS ICU, which is what we've sort of coined in the Pediatric Intensive Care Group, PEDS ANES for pediatric anesthesia, and then hashtag ICU rehab. It's really common with the adults groups out there, but it is also applicable to pediatric care as well. So what is delirium? I think that it could be, as I said, sometimes it's just this really ambiguous sort of topic that people oftentimes sort of struggle with. When you really boil it down, there's four cardinal features, which I've highlighted here. There's an acute onset and a fluctuating course, right? And there's impairments in attention and changes in cognition. Those have to be present for delirium to exist. And if you have one of these things and not the other, there may be some subsyndromal delirium going on, but it's not quite delirium. And it's really important that these key features are highlighted when you're talking about this, because then you're looking towards the pathophysiologic cause, which may be underlying it. This slide always makes me chuckle, but this has actually been published in multiple medical journals. This is Dr. Maldonado, and he's a researcher in the delirium world. And what he's outlining here is a schematic where he's trying to tackle all the potential etiologies of delirium and the pathophysiology of how it may exist in the human body. And he's got other ones that are even more complicated. By no means is anyone meant to actually read this, but but it just, again, illustrates how complicated this disease process really is and how overwhelming it can be to those who are caring for people that are experiencing it. So what about delirium in children? I think it's fairly common for pediatrics to lag behind adults in a few things, simply because studying children it's usually we're a little bit more guarded and cautious, and research in those age populations tends to lag a little bit for those reasons. They're a vulnerable population, and it just requires a little bit more effort and a little bit more forethought than when we're studying medical topics in adults. So we are, in the pediatric world, a little behind the adults in regards to understanding delirium, but we have now about 10 years, plus or minus, of solid data that's building the foundation of understanding delirium in the pediatric critical care world. We know that the prevalence ranges from 10 to 30%. That's very similar to the adult population. And if you look at subspecialty populations, such as those children who've undergone cardiac surgery, you'll see that it could be as high as almost 60%. Again, very similar numbers to our adult counterparts. We know that those people that develop delirium in the ICU have a longer time on mechanical ventilation, longer ICU length of stay, and dramatic increase in hospital costs. Again, these things are all intuitive, but it's interesting that we can point to one specific disease process that is attributable to these things occurring. And again, this is exactly the same between children and adults. What's really scary is that mortality is much lower in children that are in the ICU. It can be high in the adults. I think it's not uncommon, but in children it's actually quite low. And so what the group up at Cornell showed was that there was a fourfold increase in mortality associated with pediatric delirium. That's unheard of in caring for ill children. And so again, I think it really highlights how significant delirium can be in this patient population. So what are some of the causes? Well, I alluded to the complex nature of pathophysiology of delirium. And unfortunately, the causes of delirium amongst children in the ICU is actually is similarly complex. It's often multifactorial. So some of the broad components that can contribute to delirium is the patient's premorbid condition, or their attitude toward illness, age, and defense mechanisms. So when you think about adults, the adults that develop delirium tend to be the more elderly, the more frail adults, potentially with dementia or Alzheimer's, and so they slip into delirium a little easier compared to some of their age counterparts that are either younger, or do not have dementia or Alzheimer's. In children, it's the younger that are more susceptible to delirium. So 2 years and younger tend to be the ones that are more likely to get delirium in the ICU, the populations that have been studied. Additionally, I think environment plays a really big part in the pediatric population. It can in adults, but usually the adults they're used to being or can, presuming that their faculties are there, they're not as sort of frightened per se by the environment in of itself. But if you can imagine, even pre-COVID times, a 4-year-old with an asthma exacerbation who's in the intensive care unit, it's a very frightening atmosphere. It's going to be an unusual environment for them, lots of disturbing sounds, those pneumatic tubes banging, containers against the wall as they're delivering medications all throughout the day. Sometimes, particularly in older buildings, there's a lack of windows, so it's artificial lighting. Children oftentimes find themselves comforted with television, and so they lose deprivation of their day-night cycles. It's just all of these factors which contribute then eventually to sleep loss and fragmentation. And I'm not going to dive too much into sleep loss and fragmentation, but there's a whole body of research that's evolving that really talks about how some of these effects that we're seeing in critically ill patients are because they just simply can't establish restorative sleep cycles like we do outside the hospital. And there's a lot of research going into this. And if you can imagine all the things we just commented on those children, there's no way that they're having restorative sleep. And so again, there's this underlying sort of powder keg that just gets lighted. And delirium, unfortunately, is the explosion of all these bad things that are occurring. I like to highlight some of the patients I've cared for as I'm sort of transitioning. And this young boy had undergone a posterior spinal fusion. He was having a prolonged recovery due to sort of an acute on chronic respiratory failure. You can see in the picture he's still intubated and ventilated, but he's participating in his care. Right? He's not just laying in bed. So he's sitting up in bed. You can see there's a bucket with Legos. He's participating in fine motor skills. He's picking up the Legos. He's putting them back. Additionally, you can see there's 2 physical therapists in the room that are helping him, Behind them is Tom, one of our senior respiratory therapists, ensuring his safety while he's being mobile in the bed and sitting up and being active. Off to the side is not pictured, is the patient's mother, a child life specialist, and 2 nurses. So it really does take a village to care for these children. But you can see what's happening in this picture. Additionally, and I'll touch on this throughout the talk, you can see some non-pharmacological things that are occurring. The shades are up. Natural sunlight's coming into the room. The TV's off and moved way away from the patient so it's not distracting them. Lots of really great things are going on here in the prevention of delirium, and we'll touch on this throughout the talk. So transitioning to sedation. This slide was too good not to steal from one of my favorite nurse practitioners, Megan. When I see orders to titrate sedation to comfort, I'm certain they mean my comfort, just so you know. And this is, we have all experienced this before, this sort of notion with regards to sedation. And unfortunately, this is one of the topics where children simply are not adults. As anyone that's worked in a pediatric ICU knows, room 1 could be a 2-month-old, room 2 could be a 2-year-old, room 3 could be a 20-year-old, and then room 4 could be a 2-day-old. And with those varying ages are going to be varying developmental milestones, developmental levels. And it really makes standardization of things such as sedation very difficult. We can't use these sort of broad scopes practices. We have to almost personalize it to each individual patient. Right? And that's not just because of provider preference, but physiologically, the patient's metabolism, elimination of drugs is also going to be different. It's going to vary widely amongst those different ages that you may see in an ICU. Right? And there's these undertones, right, that not being sedated enough is going to be a safety or potential issue with post-traumatic stress disorder. This is sort of old school thinking that the patients need to almost not remember their ICU stay or they're going to be traumatized from it. And broadly speaking, this is simply a misconception. My research mentor, Sapna Kachadkar, she published this paper on optimizing sedation management to promote early mobilization for critically ill children. And in this paper, I'm quoting it here, maintaining safety in the pediatric population, i.e. the prevention of inadvertent extubation or removal of vascular access devices, often translate into keeping the child still or immobile. And it's this sort of, and I've been there. I saw this practice when I was early in my training, and we fought it really tooth and nail in my time at my current institution, trying to move past this, trying to recognize that there's a middle ground, and it's important and why it's important. And we recognize, as I said, we're only sort of scratching the surface on delirium in children, but one of the things we know without a doubt is that polypharmacy for sedation and analgesia for those children that are being mechanically ventilated is a main component, a main driver of delirium in pediatric patients. And benzodiazepines are the absolute worst when it comes to causing delirium. And that was first identified in adults, and it's shown time and time again to be the same in pediatrics. It's a very strong independent risk factor for the development of delirium. This is results from the Vanderbilt group. Heidi Smith, who was looking at, she was validating a screening tool, which we'll touch about in a second here, in preschool age children, so 6 months to 5 years. And what they found was it was almost like dose dependent with the benzodiazepine exposure and the acquiring of delirium and the prolonging of ICU like the stay. And it was you couldn't make a stronger correlation between those drugs, that drug and the outcomes that were mentioned. For those of you that are on social media, this may be a hashtag you see in the summer months, usually as medical students are transitioning into internships. And one of the ones that I stumbled upon and was reinforced in my life as a tips for new docs was that respiratory therapists are often very helpful, if not insightful, with regards to the sedation need for critically ill patients. And one of those reasons is sometimes the most stimulating thing that's occurring to a patient is when they're suctioned or having oral care done by the respiratory therapists. And I've had patients, I just had one last week, where the RT came to me and said, this kid, anytime I go in and do cares on this kid, I lose ground. It takes me 30 minutes, it takes me an hour to catch back up because they have such a tough time. And so what we were talking about is, well, do we need to increase the child's sedative infusions? But rather what we did was we actually gave a PRN sedation before cares, and with that, the patient tolerated the cares and didn't lose the ground with regards to weaning the FiO2 and maintaining the minute ventilation and weaning the amount of support that the vent was doing. And actually, we were able to decrease the total sedatives the patient was experiencing by making sure that we gave those doses prior to any sort of instigating event. And I thought this picture was funny. It's actually from an AARC write-up on how RTs can talk to physicians, and so I thought I'd include it here. I just thought it was hilarious. Okay, so here's another picture of one of my former patients. You can see here, this girl she's less than 2 years old. She was admitted with RSV to our unit. She had to be intubated. If you look closely, you can see, if you're able to see the slides, you can see this girl's awake. Her eyes are open. She's watching TV, right? She's intubated on a vent, but yet she's able to participate in care. She's not simply out comatose with sedatives, and she's safe. Her mother was typically at her bedside, right? She was great in helping us prevent any unsafe movements, right? But you can see here, just one small example of how feasible it is to engage with these patients, and even at a young age in a safe way, by minimizing their sedation and personalizing it to them as individuals. So how do we screen for delirium? This is really important because delirium is one of those diseases where if you're not screening for it, you're probably going to miss it. And we saw that in internal data at our institution, and others have replicated that as well. You simply have to look for it or you're going to miss it. And sorry, guys. So I'm just going to keep moving here. There's some questions popping up as well, which I may get to at the end. For regards to delirium screening, it was really within the last 10 years that we have picked up. And one of the reasons we've been able to pick up to where we are, is because of the screening tools. So I think that we couldn't study delirium in pediatrics until we were able to validate and screen for it, if that makes sense. So the common ones are the PCAM, PSCAM, which is the Vanderbilt group, and that's derived. So the PCAM is a Pediatric Confusion Assessment Method for the ICU, and that's for children 5 years and older, and the Preschool Confusion Assessment Method, or the PSCAM. And these are all both derived from the CAM ICU, which also came out of Vanderbilt, and Wes Ely and his group. The other, probably more commonly used pediatric delirium screening tool is Cornell Assessment for pediatric delirium, which is out of the Cornell group, and it is more of an observational tool. We'll talk on that. The newest one to the group, sort of tool for our toolbox, is the SOS-PD, and that one's really just is newer and hasn't been used as much, but it's very similar to the other two. So when you dive into these screening tools, it's really getting at the core fundamental sort of components of a delirium diagnosis, right? So the first part of it is assessing for whether or not there's a change in mental status. If there's no change in mental status, then there's no delirium. You're done. If there's been a change in mental status, then you need to sort of check for attention. So or inattention rather. So one of the ways to do that is simply have a task where you ask someone to follow a command. That's where you get sort of squeeze my hand when I say the letter A, and then you rattle off, 10 various letters, A, B, A, D, B, and you see how many they get right, how many get wrong. If they get multiple letters wrong, then you need to assess for their level of consciousness. Perhaps they're oversedated, and that's why they're not able to follow commands, right? And so if they're oversedated, you really can't say whether they're delirious or not. However, if their sedation is not a problem, then there's likely delirium, and then it gets into some fine-tuning of whether or not it exists based on assessing for disorganized thinking. And I think this is fairly intuitive, and it's very similar to the CAM ICU. But how do we assess for delirium in babies, So as mentioned, the PSCAM is 6 months and older. And with that, right, it's very difficult to ask an 8-month-old to squeeze your hand, right? That's not going to work. So what do? They created these bright cards, and one of them is actually a reflective surface, and you slowly advance it across, slowly pass it across the baby's face, and it should draw their attention. Their eyes will track, and that is how they're showing attention in that aspect. And so you'll flip through the cards, just as if you were asking them to squeeze your hand with a certain letter. And that's how you're able to assess for attention in babies. And it actually is quite effective. And this is what we use in our unit. And what's great about this is in the moment, if there's a question, you can take this tool to the bedside and assess a patient for delirium. It's a bit cumbersome, though, right? There's these certain tests you have to do, and it can feel like it's a little bit clunky, especially if you haven't done it recently. Whereas the CAPD is rather, I think it tends to be the more adopted one, because I think the bedside nurse appreciates it a little bit. It's a little bit easier in their workflow. It's based on observation, so they simply take care of the patient as they normally would for up to 4 to 6 hours, and then they sort of pops up on their screen to fill out the CAPD, and then they go through it quickly and fill out the CAPD. And typically, it's sort of, again, it's a little easier for the nurses to incorporate that in their workflow. What's nice about the CAPD is there's developmental milestone anchor points, which are helpful, and that's why the CAPD can be used from, they say, and has been validated, from birth on up until adulthood, which is a little different than the PCAM or the PSCAM. So both are validated, both work, both are used all throughout the world, but you can see here, based on how they're used, it's a little different, and why maybe the CAPD is a little bit more popular. So I think this is sort of, this is Micah. He was one of our former heart transplant patients. He's amazing. I like to include this slide because Micah had hypoactive delirium. Hypoactive delirium, it's one of those things where if you don't experience a patient with it, it can be hard to really understand how difficult or how it can be to care for these patients, right? Because if you can imagine, right, the patients that usually get our attention are the ones that are hyperactive, the ones that are safety risks, the ones that are trying to get out of bed, the ones that are trying to pull up their tubes, pull out their lines. The patients that just simply sort of sit there, lay there, those are the, quote unquote, those are the good ones, the easy ones. We don't sort of go looking for reasons that things could be wrong in those patients because they're cooperative in a sense. But actually, the adult literature shows that hypoactive or mixed subtypes, which have features of hyper and hypoactive delirium, tend to have worse outcomes. So without delirium screening, we would often miss these hypoactive patients. And I still feel like, in general, pediatric delirium as a sort of in the critical care community is not quite quantifying as much hypoactive delirium as exists. So it's definitely a point of emphasis. And sometimes when I was chatting with Micah, it was sort of when the RTs were coming by to do his cares. They were working with him on a cappella, and they were doing a bunch of sort of, he had some atelectasis he was working through, and it was sort of that they were some of the bedside nurse really wasn't the one that noticed it, but it was a respiratory therapist who was coming by with him intermittently throughout the day. And sometimes the RT workforce is a little smaller, so actually the RTs got to know him a little bit better than the nurses workforce. It was a little larger. So you can see here how important in that role, it's a very subtle role, but that the RTs are playing in his care. For those of you that are on Instagram, I came across this account, which is like memes RRT, and it's like RT themed memes, and I died when I saw this one. This was because we've all been there at the end of a long shift where you're this little young girl and you've got a unicorn face painting and you're just defeated. And sometimes that's what it can be like caring for children in ICU. But in the end, right, you leave smiling with face paint. So it's all good in the end. So as we'll transition now, talking about the prevention and treatment of delirium, I think that it's really important to recognize that delirium is everyone's problem. This is an article that talks about the Johns Hopkins Delirium Consortium. Dale Needham, who's a picture on the left, and Karen Newfield, who's on the right, come from different specialties, but they both are combating delirium in their own unique ways. And what they realized really was that we needed a platform that got all the stakeholders together and was able to then sort of, break down those barriers and figure out how we can address delirium at an institutional level, because it's going to vary. What's worked at Johns Hopkins may not work at Pittsburgh, may not work at Texas, and so it can be, but there can be similarities, and there can be subtle things that do carry over in different cultures, in different institutions that will be important to pick up, and that was sort of how things got started at Hopkins, and it's really been successful in that regard. And one of the things that sort of has, I want to say, sort of revolutionized ICU care over the last 5 years or so really has been the ABCDF bundle. And this is probably not new for many of the people in the audience. However, I would venture that most of you really hadn't gotten past sort of the breathing portion, because that was sort of your domain of expertise. But if we really look closely at this and we think about some of the topics we've already talked about, you can see where respiratory therapists actually have a lot of input and a lot of potential avenues for helping patients. So we're just going to go through each one briefly. So A is for assess, prevent, and manage pain. And we talked about this. This could be when the patient's getting their suctionings or they're getting cares that they may not have adequate analgesia-based sedation. Right? And so one of the things that's been advocated for recently is sort of fentanyl as an opioid infusion to address analgesia-based needs. The pain of the endotracheal tube, the pain of the cares that are going on. Right. B, again, is rather common, but it's newer to the pediatric world. At least our institution now, we're going on year 2 or 3 now, where the SBTs, spontaneous breathing trials, are becoming more common. It's definitely something that I think has sort of shown benefit in the pediatric population. I think picking the right patients tends to be one of the most important things, one of the most important parts of the SBT, making sure that your patient's there. But I've had colleagues who are worried about extubating a patient, and so an SBT trial sort of was a way for them to challenge the patient and feel more comfortable about their readiness for extubation. I think that what we've seen in the adults is there's faster liberation from mechanical ventilation. I'm not sure if that's happened in pediatrics yet, but I think we're inching towards it, and it's rather important. And I won't belabor this any further, but it's an obvious part of the bundle where RT expertise is very helpful. Choice of sedation, I highlighted this a bit. It's mainly sort of that avoidance of benzodiazepines being key. Dexmedetomidine is wonderful, again, because it doesn't affect respirations, so it doesn't as much, right? So patients are able to sort of cooperate with the vent a little bit better. It's more of an anxiolytic, which is quite nice, without the patient sort of having to be knocked out. And then it's also, we think, is sort of, from a physiologic standpoint, doesn't have some of the negative sequelae of those other medications. D for delirium, again here, I think that this is the part that it really encompasses components of all of these aspects of the bundle. It's highlighting routine delirium screening. The non-pharmacologic interventions are really important. Shane, one of our RTs in our unit, he's great at helping be an advocate with making sure the shades are up in the rooms, talking to the families. I think once you have, all the care team members are aligned to the common goal, it normalizes the care, and it doesn't feel like, that we're picking on people, or that, the family members don't feel sort of, if the RTs, the nurses, the physicians, everyone's talking about the benefit of natural lighting and having the shades up, then they understand it's not sort of one person's prerogative, but it's more of a mission, and I think that's really helpful. And then early mobility and exercise, and this is relatively new in the pediatric world. So this is what we're going to spend the rest of the talk really highlighting how this is done effectively, and stressing the importance of the respiratory therapist in doing this successfully. And so, as the pediatric world was adopting the ABCDF bundle, the group at Johns Hopkins came up with the Pick You Up group, which is, the name's a little on the nose, but it's good branding. But really, it's getting patients up, getting them out of bed. And so, early mobility is a key feature of that. And as I was preparing for this talk, and I was going through patient pictures, it struck me that in almost every patient picture I have of a child in the ICU, there's a respiratory therapist at their side. And I think that speaks to a few things. One, it speaks to the importance of respiratory therapists in the care of critically ill children, but it also speaks, these children usually are on some sort of advanced airway support, whether it be mechanical ventilation, high flow, what have you, tracheostomy. Right? And for them to do any of these things safely, they're going to require the expertise of a trained individual, such as a respiratory therapist, to keep them safe in this venture. You can see this young boy here. He was in a motor vehicle collision. He's still in his C-collar. He's still intubated due to pulmonary contusions that he was slow to recover from. We had his parents bring in his clothes from home, his shorts, his shoes, and he was able to get out and walk around the unit. And I guarantee you this improved his recovery. It decreased the amount of time he spent on the ventilator because he's up and out of bed, and he was able to avoid getting delirious. And so Pick You Up it's a bundle care as well, very similar. It's the ABCDF bundle for pediatric patients. And what it does is it has this sort of activity progression, which is really important. And so we'll just spend a second here highlighting this. Activity progression. So level 1 is the baseline. And you can see some of the non-pharmacologic strategies that are commented on here. Lights on, shades up by 9 a.m. bed bath and weights being done by 11 p.m. When we were evaluating these tendencies in our unit, what we found oftentimes is that children were getting bathed at 2 a.m. Can you imagine? Children were essentially being woken up to be bathed in the middle of the night because that's when it was convenient for the nursing staff, right? But that's horrible for that child's sleep hygiene. And so by pointing out that that wasn't the best thing for the patient, recognizing it, and then putting in sort of these guidelines on when it should be done by, we've been able to avoid those sort of things from happening in the middle of the night. Actually trying to turn the lights down or in patients' rooms where it's safe and appropriate, and using 11 o'clock at night as that target. Trying to limit TV time. It's we all suffer or struggle with this, I should say. These children are often sort of captives, and they're starved for attention or interaction, and it's difficult. And so sometimes we rely on electronics, even in the hospital setting, like we may at home. But nighttime is not when this should be occurring. This is when sleep should be happening. The TV should be off, and it's hard. That sometimes is a really hard part for us because maybe it's the parents who are wanting to watch TV in the child's room, and it's keeping the child awake. And so there's a lot of difficult conversations that sometimes need to happen. But again, if all of the team members recognize the benefits of this, then it helps sort of normalize the behavior, and families then adopt it a lot easier. Little things here like positioning, turning, very important, but oftentimes may involve the assistance of a respiratory therapist. That's always going to be there. Level 1 always exists. Now, patients who are able to have to do slightly more active things sort of reach level 2, and so it's always level 1 plus additional things. And these may be children who can have, infants and toddlers who are having positive touch, so desensitization, because they're, babies that are first born and intubated, sometimes they aren't held or touched, and so they get really sensitive to that happening. So if you can incorporate that in their care early on, then it helps, and actually when they get older, they don't require as much sedation to remain safely intubated and ventilated. Getting up and sitting up in the bed, whether it's on the edge of the bed or out of bed, multiple times a day, is really important. And as well as this, as we then sort of transition into level 3, which is out of bed and sort of ambulating. And the reason that level 2, level 3 are really important is because what happens is these patients, they just like any of us, right? If you're participating in the daily activities of life, you're getting out of bed, you're walking around, it's going to have more of a physical toll on you. When you're critically ill, you don't need to be going to the gym and doing, a treadmill session. But these kids simply need walking, 20 feet is the equivalent. And what that does is then it tires them out. They get fatigued, right? And then they sleep at night because they're tired, and their body then has those restorative phases of sleep, which we alluded to at the beginning of the talk. And it's really the key foundation, the key crux of the ABCDF bundle is to have mobility in there. And it's important because it's that exercise, right, that gets you to the sleep. And this is one of our oncology patients, and you can see here he hated walking, but he wanted to ride a bike. So we brought an exercise bike. We borrowed it from our adult ICU and parked it in his room, and he would ride the bike, I think 4 or 5 times a day. You can see here he's dabbing one of the pictures, right? Even though he's on high flow nasal cannula, right, he still is getting up and he's moving and participating in care. And he talked about how at nighttime he would quote unquote pass out, go right to sleep, and he hadn't slept that well in a long time, and he attributed it to being able to sort of get on the bike. And this requires, again, effort, requires team members. You can see here he's got a chest tube in place, right? He's got a central line. You've got to navigate all of those things. He has an arterial line still in place, right? And his high flow nasal cannula. That takes a lot of effort, but it pays off in the end because it allows for him to have that sleep that he needed. And this isn't limited just to big kids, right? You can have young school-age children, right, getting out of bed, right, on the ventilator, sitting up, right, minimal sedation, babies, right, same thing, propped up in bed, right. This is helping in this child's, or normalizing this child's care a bit, and it's going to help them in their recovery, right. And then moms holding their children. I think this is one of our cardiac babies, and this is as good as it gets sometimes. I mean, honestly, the babies, you can see a mom when a parent, not just a mother, but when a parent holds the baby, sometimes their heart rate goes down 20 points, right? That's the best sedation that exists, is sometimes it's just being held. And facilitating that in a safe way is going to require the expertise not only of a bedside nurse, but a respiratory therapist, because the positioning is really important, being able to learn those subtle nuances are very, very important, and it's quite helpful. And then yes, sometimes even we find ourselves bringing livestock to the hospital. This is one of our patients who was she was almost, I think Reese was admitted for almost 2 years, and she was in a horrible house fire, grew up at a farm, dairy farm, excuse me, and she really missed her cow. So her parents decided they were going to bring her Bessie to Johns Hopkins to meet her, and who's at her bedside to make sure it happens safely? One of our respiratory therapists. Again, a sick patient isn't going to go anywhere in a hospital without an excellent respiratory therapist at their side. So as we're wrapping up here, final thoughts. I think this slide says a lot. Whether it's your personal experience or the experience we've seen in patients or family members, there's this expectation that, once the patients recover from sepsis or once the big surgeries happened, they're just going to get better. And we all know that unfortunately that doesn't happen. There's ups and downs, turns left and right, the squiggly line of reality that we all live in. But hopefully in the end, right, we're making that line less and less squiggly and more straight by doing some of the things we talked about today. And what's important, right, is that we these silos of sedation, sleep, delirium, rehabilitation, or early mobilization, we can't talk about them in isolation. As you've seen from this talk, if we talked about sedation and we don't comment on delirium, right, that's a major component of delirium. And likewise, if you talk about delirium and you're not commenting on what the patient's sedation plans are, then again, you're underscoring the relationship of these things. And without understanding them, right, in totality, you're really not going to achieve much because they're all integrated. They're all this sort of machine with gears. And if one of the gears is malaligned or missing, the machine isn't going to go anywhere. And so hopefully I've demonstrated that respiratory therapists are key stakeholders in the care of critically ill children. Right? They have the power and expertise, I think, to ensure that things such as non-emergent interventions are clustered, right, with the goal of optimizing, right, mobility, communication, right, so that these patients are wakeful during the day, participating as best they can in efforts that make them tired so they can sleep and reach restorative sleep at night. Right? There's certain things that just are no-nos, and we need to try our best to avoid them, such as benzodiazepines as deliriogenic drugs, right? Making sure that we're addressing the analgesia component first, right? Starting low and going slow. As we've seen, it can be done safely in small children, right? And then I think it's time for us to recognize that critically ill children can tolerate an endotracheal tube and communicate with us, even when they're young. It doesn't require a 17-year-old onc patient to be able to achieve this, right? And there are lots of non-pharmacological therapies, right, in collaboration that is needed, as I've highlighted, PT, OT, RT, SLP, child life, all very, very important in the care of these complex children. I just want to highlight some maybe lesser-known delirium avenues for those that have become interested in this. We just recently celebrated World Delirium Awareness Day. Again, this is more of a social media campaign that leverages a hashtag. And what we do is we really try to bring awareness, as it says, but because without awareness, you can't drive change. And what's really, I find really, every year, this has been going on for, I think, 7 years. And what I really think I've found as a takeaway for me personally is that I'm able to follow along on how other institutions have adopted techniques to bring awareness to their units, because it's going to depend on your own personal institution and culture on how to best achieve these things. And it's important to recognize there's not just one way to achieve it. And that's one of the things I think that really comes out of World Delirium Awareness Day. For those of you that end up really getting interested in delirium, the American Delirium Society has its annual meeting. It's still online this year, so it'll be in June, and remains virtual. This is a great place for all stakeholders that care for delirium to learn more about the topic and or to share their research, whether it be quality related or clinical or translation related. And then for those of you who want to dive deeper into the topic, ICUdelirium.org is out of the Vanderbilt Group Critical Illness, Brain Dysfunction, and Survivorship Center Wes Ely, sort of the the founding father of ICU delirium, and he's a wonderful advocate. All of the resources are available for free. So the PSCAM cards, the PCAM, PSCAM screening tools that I highlighted earlier in the talk are all available for free. And here are my references. And I'm starting to see some questions popping up.
Okay,
so
thank you, Dr. Barnes. Sorry, my
ahead,
mistake. Go ahead. We'll go ahead and do the questions, and then after I'll go ahead and close everything up. So yes, there's some great questions here. So go ahead, Dr. Barnes.
Thank you. It was good to hear someone else talk, so I'm sure you guys are getting tired of just hearing my voice. So the question I have here, first one is, how has long-term effects of delirium been found in children post-hospital? That's a great question, Kelly. Thank you. If you can imagine, I would say over the last 3 years or so, we're starting to see research that's been published on adults, patients who are having long-term effects of delirium. So if you extrapolate based on sort of the lag we have in our research, we're not quite there. There have been, when I recently wrote a book chapter where there was 2 published articles that had tried to look at neurocognitive effects in patients that have had delirium, and it showed that in children the one group didn't show any difference. However, the concept of post-intensive care syndrome, or PICS, or PCIC, or PICS, is relatively common in both adults and children. SCCM made, I believe, post-intensive care syndrome was the hot topic 3 years ago, and so really we're just starting to scratch the surface here on this topic as well. Clinics that are evaluating children post-ICU in general are looking at those that have had delirium and not had delirium to see what the impacts are. But I think we probably will see some differences, but it's going to be really difficult to tease out because, again, the differences may be really subtle. Another question here from Susan: do you have any idea what the RT patient ratio is to do these things? And so that's a great question. We have the ICU Rehab Conference. It's the Johns Hopkins ICU Rehab Conference. It's an international conference hosted in Baltimore. It's been virtual for last year with the coronavirus, obviously, and then I think the organizers decided this year should be as well. That's Dale Needham is the leader of the adult track, and Satmika Chadkar is the leader of the pediatric track. And what we do here, the whole point of that conference is essentially how to help people create early mobilization, ABCDF bundled sort of featured programs at their own institutions, and it talks about the nitty-gritty. And so I think that I would not want to answer that question incorrectly, but I would direct you to that resource, because Krista, one of our lead RTs, she has 2 or 3 talks she gives specifically on how RTs can safely mobilize children. And so I know that we tend to have a fair amount of resources in our unit. So in the cardiac ICU, we have 12 patient beds, and we have, I want to say, 2 to 3 dedicated RTs and on a charge that can swing over, and that's not accounting for any ECMO specialists. So it can be quite intensive, absolutely. But it may just depend on if you have aides or other people that can help sort of float and do coverage, which again is what the unique culture part of this whole program really is. Brad, do you see any other questions?
I do not, but I have one question if it's okay. So first of all, great presentation. I really enjoyed it and got the wheels really spinning. This is great work, and I work with Dr. Erica Fink, and we've done some of this in a little bit of a different model. But I think what you demonstrate is awesome, the scores. Can you tell us a little bit about the evidence in terms of ICU length of stay? and if it's kind of is it multi-institutional, is it randomized, any kind of evidence that pertains to this? Because I think with some of the questions that popped up about, what are the ratios, it comes down to, that benefit. And if you can show that benefit, then you can staff the unit a little bit better. So can you speak a little bit to the evidence about the outcomes, length of stay, ICU length of stay, things like that?
Sure, thanks. Great question, Brad. COVID probably is going to reset a lot of our statistics on this. Pre-COVID, there were a couple papers that came out regarding the ABCDF bundle. I believe one of them may have been in JAMA, and the other one was in critical care medicine. And I think it decreased time on the vent by over a day, and I think length of stay was similar, and which I think makes sense. I think it might have been 2 days, but it's hard. It was hard to say for sure because reproducibility was challenging in some of these institutions. Because it's when you tackle this, you have to tackle all the components. If you just do a little bit here and there to see a major difference, you may see incremental improvements by doing one or two of the things. But given that they're all interrelated, it's really challenging if you don't sort of try and do all of them to the best of your ability early on in the process. And in pediatrics, I don't think anyone has shown yet if there's been a difference, but I imagine it'll be similar.
That's great, good information, and I believe Joshua has a question for you there, Dr. Barnes.
Thank you. The question is, in transport, what would you consider to be the best practices since a lot of these practices cannot be utilized? Our transports are usually a lot longer than most since we do international transports. Well, I think the transport is obviously going to be it's a little different. The crux of the talk was on patients who are in ICUs, but what I've seen in a few transports is again sedative choices can be different, and I think the premise is still there with regards to doing if you're addressing what's uncomfortable for the patient, which is usually likely the endotracheal tube, with more of an opioid based. Or if they're older and you think it's anxiolytic or you need, dexmedetomidine, I think that is still really important. And that's what our go-to is typically is fentanyl and Precedex or dexmedetomidine. And then say we have a patient that is really difficult to sedate, and what we tend to do is we use enteral Valium. So we're trying to avoid the IV benzos, especially short-acting ones like midazolam, and I think we're seeing less. And it's anecdotal at this point because it's not something we particularly study, but it seems to me that we're having less patients with delirium with that sort of regimen. So that's probably something you can still adopt in a transport sort of mode. But I think that it's, and then you're going to be a little bit limited. With the transport, I think safety is going to be really important for both providers and the patient. And so that's one where, and it should hopefully be temporary, but I think sedative choices can still be important in that situation. And then I think there's time for one question, so I'm going to answer Susan. I work in a level 3 NICU and would like to know if your topic is applicable to my population. Thank you, Susan. Yes, that is a little sort of, I don't want to say controversial. One of the reasons that we adopted the PCAM at Johns Hopkins is because delirium in newborns, like, what does that mean? Does that mean anything from a developmental standpoint? And so it's a little tricky, but there's some core principles, right, with regards that I think even the neonatologists have started to recognize. And one of those is, again, getting back to sedation. I can't tell you how many times I would, go to pick up a baby from the NICU for to take to the operating room, or care for them when I was rotating through the NICU as a trainee, and they were, weren't on any sedatives. And they're like, oh, they don't need it, they're a baby. And I think we've recognized that, again, sedatives are important, especially analgesia. Now, I'm not worried about babies forming memories, but babies still shouldn't feel pain. And so I think that it's important that they likely have at least a narcotic or opioid of some kind to try and tackle the pain that can develop from the endotracheal tube as they get a little older and recognize that. Newborns that are just a few days old, sure, I can understand that. But there are places, NICUs, that are adopting to pick you up program, because again, a lot of that, level 1, level 2 is simply sort of, engaging with the patients, safe, being held. I can't tell you the smiles that are brought to people's faces when, parents put their sick babies in wagons and take them for wagon rides around the ICU. And in no way is that baby sort of, exerting physical effort in a wagon ride, but it is different. It's a little bit more stimulating for them. They tend to still have a little bit of, that change by getting out of the room, getting out of the wagon. They do get tired afterwards, just like they would if they were a baby that wasn't in the ICU. And so those are applicable to any location. But I think the NICU still is a little bit, they're not quite on board with delirium yet, and I don't know if I would hold that against them.
Okay, are there any other questions from the group? If so, you can go ahead and put them in. Okay, Dr. Barnes, thank you again for joining us today. It was an amazing talk and very thought-provoking, so great work, and it was excellent. Also thank all those that attended today's webinar. Please join us next Friday, April 16th, for the April 2021 Journalcast with Dr. John Emberger. He'll be presenting an excellent topic as usual. I've heard John present it several times. He's very, very good. And then on May 5th, join us for the panel discussion on learning in the pandemic and the impact on clinical education and new hire orientation. I want to thank everyone again for joining us for this excellent presentation today. And thank you to Dr. Barnes again as well. And this concludes the presentation. Thank you.
Thank you. If you're a group participant, please have your group leader submit your information to the group attendance tab to be provided with the follow-up instructions on how to submit for credit. If you have any questions, please email crce@aarc.org. This concludes today's presentation. To submit for credit, please click on the Credit Submission tab. Once finished, you may simply exit out of the browser window. We hope you have a great afternoon.